Please no. Okay. Forearm, so I'm starting to get into below the elbow. Forearm midshaft fracture, radius ulna. Common can be an isolated, just radius or just ulna, or in combination. See these all the time in the emergency department. Nightstick, also ulnar midshaft fracture. Why do we call it nightstick fracture?
Like the.
Because you got hit with a nightstick, yeah? I think that was kind of a term back in the 60s and 70s when the police, I think, weren't as nice as they are today. And they just used to beat people with nightsticks all the time. And, you know, you go up to block your arm and you get hit with a nightstick and you get a nightstick fracture, right? I'm sure that's right. Monteggia and Galeazzi fractures, super cool names. Easy way for an orthopedist to pimp you on something. Learn it, memorize it. Doesn't really matter for clinical practice, but know what those two are. I think we're going to go over there in a second. Just so an orthopedist talks about, well, what is this, and this, and this? You're like, oh, well, that's like a Galeazzi fracture. And they're going to be impressed. Both bone. What do you think that one is?
Both bones.
Both bone, yeah. Nightshift fracture, midshaft ulnar fracture, blocking the nightstick. Galeazzi fracture, defined as a radial midshaft fracture associated with a radial ulnar joint instability. Midshaft fracture, radial ulnar joint instability. Monteggia, fracture proximal third of the ulnar shaft associated with dislocation of the radial head. Proximal third ulnar, dislocation radial head. Monteggia. Monteggia. Proximal third, dislocation radial head. Monteggia fracture. Galeazzi. Distal fracture and radial ulnar joint instability. So you can kind of, on this one right here, it doesn't really look as bad, but you can see how this, that distal end of the ulnar there is just like sticking up and out of place. Right? Distal ulnar radius fracture, radial ulnar instability. Galeazzi fracture. Cool?
Yes.
Does it really matter that you know those two dead guy names?
No.
It only to pressure or release. That may be a test question actually, like a PANTS question or something. You know, one of those tricky ones. Anyways, isolated midshaft radial fracture, ORIF, recommended within 1 to 2 days. Nightstiff fracture, non-operative casting splinting if the following criteria are met. Greater than 50% apposition, so that's how the bone fracture segments line up. So at least greater than 50% of it has to be in line. If it's more than 50% distracted, then you can't do just casting. Less than 10 degrees angulation, so that's going to be the angle in which it is. No radial head dislocation, and fracture within the distal 2/3 of the ulna. Galeazzi, Monteggia, splinted, and then ORIF. All right, distal radius fractures. One of the most common fracture site of the upper extremity. Often called Colles or Smith fractures. Characteristic dinner fork deformity. Fall on outstretched hand. You're going to get those all the time. People fall right here, break the radius. Swelling, tenderness, palpation, I mean, you get it. So, Smith fracture, flexion fracture of the radius. So, extension fracture of the radius. So, Colles, so you're going to have dorsal and palmar fracture. What am I trying to think of? I'm sorry, I just blanked. It's going to be where your fracture segments are displaced to. So, Colles fracture, I don't know why I keep on getting so close to my pointer. Your distal fracture segment is dorsally displaced, right? And the Smiths are palmarly displaced. Okay? I think I've articulated that better in the notes, so I apologize. Dinner fork deformity. I mean, I guess, yeah, it looks like a dinner fork. You can see that. It's like, yeah, you broke your wrist. Right? Should not look like that. Okay. So how would we describe this fracture? So this is a 3-view, right? Lateral, oblique, anterior, posterior. How would we describe this fracture to an orthopedist or to anybody? I mean, you just need to be able to describe it when you're doing your wet reads. Assuming that this is a close-up. Can't hear you.
Closed left radial.
Closed fracture of the distal left
Radial.
radius. Right. I mean, I would say there's somewhat, okay, good job, guys. There's somewhat of a combination here. I mean, that fracture set, you know, it's tough to say whether those are two distinct fracture segments, it's just jagged, or whether it's just kind of ruptured in there. Like I said, those combination, oblique, things like that, those things don't mean a whole lot to me, other than the fact that you get the anatomical location of the bone, the site of the injury, and then whether it's closed or open. So what is this right here?
Split.
Yep, it's a splint. So this is likely a post-reduction film that they reduced. We didn't see the first one. See this kind of this angulation here, right? So I mean that's obviously going to be ORIF, but these fracture segments appear to be well aligned on this AP view here. You're not going to be able to get those wrist segments put together perfectly. Getting them close to anatomical alignment is good enough. Displaced, non-displaced. So displaced need close reduction prior to ortho referral. There's greater than 20 degrees of dorsal angulation or fracture segments greater than 2/3 the width of the radial shaft. We need to do some surgery on that. Methods. So relocating a closed fracture of this radius is sometimes tough, especially if the ulna is intact. Got a lot of tendons, a lot of thick sheaths that are holding that wrist together. So sometimes it's tough to get that pulled over and through. There's a couple things you can do. Traction, counter-traction, kind of what we talked about. Basically, just putting a towel on somebody's elbow and having somebody pull in the opposite direction and you pull forward trying to get those segments realigned. Or you can try some finger traps. So these are kind of like, literally like the Chinese handcuffs things you put on your finger, and you hook them up to an IV pole and give somebody a bunch of Ativan and fentanyl and just kind of get their whole body to just relax and chill out. And you kind of just let it hang there and just let the body's natural arm weight pull those segments apart gradually and put it back into place. And then ORIF after reduction. A quick way that you can do traction, counter-traction if you're by yourself, if your nurses are busy on a shoulder. You put the patient lying flat on the bed, and obviously their affected arm is sticking out here off their shoulder. You get a long sheet or a draw sheet, tie it into a circle, put the one end of the circle lying on the arm, so think of me lying on the ground, my arm's bent. One end of the circle is right here, goes around, and then comes around here. You hold their hand, and then you take your foot, stick it in the bottom end of the circle, push down, that's your traction, pull up on the fingers, that's your counter traction. That's kind of a quick down and dirty. If you don't have somebody there to hold traction, counter traction for you, you can kind of just give yourself a little bit of the juice and pull it up over. Don't trip and like push down really hard. I think that'd be kind of bad. But you can kind of do that as kind of a down and dirty ER thing. Split with a sugar tongue and refer to ortho. All right, Jesus, we're in the wrist already. Good. Scaphoid fracture, scaphoid, however you want to say it. Most common carpal bone fracture. It's difficult, secondary to its blood supply, can lead to problems. It's missed. Most are occult, meaning they don't see them. You guys know about the blood supply to the scaphoid, navicular bone, whatever you call it, right? So dorsal branch, radial artery, we don't need to go. It's retrograde. Pain and tenderness, the anatomical snuff box. Why do you think I had those capitalized? Sure. Important. Oh, somebody said test question. Very no nonsense. I'm really like, yeah, test question. I'll help you guys out. Anatomical snuff box, right? You Here's your borders. You should already know those from anatomy. 3-view x-ray of the wrist, and you can get scaphoid views. The most common fracture location are at the waist of the scaphoid. More proximal fracture line, the greater the risk of avascular necrosis because of the blood supply. MRI is suspicious for a scaphoid fracture, and a negative x-ray. So that's if somebody comes in, they have a tenderness of the anatomical snuff box, your x-ray looks negative, you're going to put them in a thumb spica splint. Why do you think thumb spica is capitalized?
It's important.
That, I mean, if that's not going to be a test question on this test, it's going to be a test question on your pants, I can guarantee it. Because that's a huge deal for liability of a missed scaphoid fracture, not putting in a thumb spica splint. They get avascular necrosis and all sorts of tendon arthropathies and stuff for the rest of their life, and then all of a sudden they're on 100% disability because they can't move their wrist, and they're suing you for $3 million. So put people in thumb spica. Anytime somebody's wrist is injured, press over their anatomical snuff box. If they have anatomical snuff box tenderness, put them in a thumb spica splint. It does not matter if the fracture is negative, if they, you examine them, and then all of a sudden they're shooting basketball hoops 5 minutes later, just put them in a thumb spica splint. It's a CYA thing, just do it, because sometimes you cannot see that fracture, and it becomes more clinically evident later. AVN here due to not using the fracture segments. Obvious scaphoid fracture, right? They're always not so obvious on the x-rays. So it's not uncommon, and it wouldn't be unusual, and I think it would be right on par, putting those people in a thumb spica splint and telling them if it still hurts in a week, that's the typical, like a week is usually what I give people for musculoskeletal injuries, is a week. Still hurting in a week, come back, get re-x-rayed with scaphoid view, or just get an MRI and look for that, right? Wrist-Triquetrum fracture, second most common carpal bone fracture, again, Fouche, point tender dorsally along the ulnar border within 1 to 2 centimeters of this ulna, immobilization of the volar wrist splint, and slight extension, okay? Triquetrum fracture. You guys know all the carpal bones memorized? Good, because when you're on rotation with me, you can help me out with it. I was going to Google it. Yeah, I probably should type that. Anyways, all right. Carpal tunnel syndrome. Are you guys cool with these? I mean, obviously there's more bones broken in the wrist than your scaphoid and triquetrum, but those are the two most common. I'm not going to go into all the other periluminate dislocations and all the different stuff that you can get with connective tissue disorders and stuff like that. That's going to be something that you deal with on an upper extremity orthopedic rotation. Cool?
Yep.
Okay. Carpal tunnel syndrome, oh my gosh, you see this all the time in primary care, in urgent care, and especially in orthopedics. People come in with carpal tunnel syndrome. Complex symptoms caused by pressure along the median nerve, right? Median nerve, carpal tunnel syndrome, median nerve. Man, what? I had a student one time, and I want to say that it was from here, but I'm not going to say that. I want to say that it was from here. Then I was like, what nerve comes from carpal tunnel syndrome? And she's like, radial. No.
Oh, no.
Try again. Ulnar. One more time. It's only one left. And then she couldn't come up with median. I was like, it was mind-boggling. Anyways. So don't know this, please. I mean, that's so simple. Risk factors, all this stuff. Repetitive hand use of the hand and wrist. What SE, I think it's called. Anyways, people that type a lot, people that use their hands and wrists a lot, repetitive, anybody that does, small things with moving the wrist a lot. And it's a repetitive overuse injury is typically the mechanism. And you guys remember in anatomy, the carpal tunnel and the carpal sheath and how thick that was. So that, that you can see how get inflammation, there's not a lot of space for things to move there, and you can see how that nerve gets compressed. So a hallmark is pain, paresthesia along the medial nerve distribution, right? Severe cases can have weakness and atrophy of the thenar eminence. So you see them in really bad cases. I mean, their thenar eminence becomes atrophied and like almost concave. It's crazy. I know that's obviously like a very bad case. Phalen's test, Tennille's test. hand elevation test. Know these two. There's going to be test questions somewhere along the line. Know the median nerve thing, right? Median nerve. We kind of discussed that. Ulnar nerve, radial, right? Phalange test. Flex the wrist to a maximum for 60 seconds. Reproduces the pain in the area. Tin heels test. Tapping over the transverse carpal ligament produces the shooting pain, right? So basically, you're just, reproducing the compression along that nerve just by manipulation of the hand. Phalange, tin heels, carpal tunnel, median nerve. Know your distribution, right? Non-surgical, so it's kind of what you want to start out with. Wrist splinting, volar wrist splint, steroid injections, NSAIDs, activity restrictions. Got to stop doing what's producing the effect, right? And then you can also get a carpal tunnel release and decompression. And man, that surgery is like just so fast. They cut open, then snip the ligament, and then put it back together. It's like a 20-minute surgery. And this is what it is. Ulnar Tunnel Syndrome or Cubital Tunnel Syndrome, same thing. Basically the same pathology as carpal tunnel syndrome, except it's your ulnar nerve, right? Ulnar tunnel, Guion canal, most likely compressed by ganglion cyst. Cubital tunnel at the elbow, conservative treatment, decompression versus transposition. So you can ulnar nerve transposition, kind of move that nerve around or outside of the tunnel so that it doesn't get compressed. And treatment conservative. And so instead of having, your median nerve distribution, you're going to have your ulnar nerve distribution, right? All right, wrist ganglion cyst. So one of the most common soft tissue swelling, benign in nature, it's a fluid-filled cyst. Most common location is the dorsal side of the wrist. So on the dorsum, you can see it right through here. It's going to be just kind of filled like a cystic mass. And just kind of like a little cyst right there on the top of the wrist. And it can cause some pain sometimes, and sometimes it's just there, and people kind of freak out about it. Non-surgical reassurance. You can do some cyst aspiration. I've had some Guthrie firefighters come in and wanted me to stick a needle in it, and I was like, whatever. I mean, it'll come back. Book smashing is no longer indicated. But that was like a deal. You just put your hand on the table and they smash the crap out of it with a book, rupture the cyst, and hey, you're cured. I don't smash people's hands with books anymore. There's better ways of doing things. And then surgery, if you really want it, you can do a cyst removal. Must remove that stalk to get rid of that fluid from the accumulation, or it's just going to come back. But most of the time, people live their entire life with these things, and it's not a big deal. Right? Ganglion, cyst. Don't smash it with a book. Test question. Don't say. What not to do with ganglion cyst? Aspiration, conservative treatment, surgery, smash with book. Metacarpal fractures. All right, so now fractures of the hand. Common fractures of the hands, broad array of injuries that produce the fracture. Key point is to stabilize and refer to ORIF in most cases. We'll discuss some variants, boxer's fractures, Binet fractures, and Rolando's are some of the ones we can discuss here. Boxer's fractures, metacarpal neck, 4th and 5th ray. So kind of some neat trivia. And trivia, I don't know, it's not trivia. I don't even know if it's neat. The fracture of the 4th and 5th metacarpal is not the most commonly fractured bone in a boxer. It's like the 2nd and 3rd. So for whatever reason, they decided to call this 4th and 5th a boxer's fracture, but when you actually look at the stuff behind actual boxers that fracture the hand, that's not the most common bone fracture. I don't know. Anyways, that's 4th and 5th fracture up, you can see. So, how would you describe this fracture? Closed? Oh my God, you guys are great. That's 50% of the most important stuff.
Left, 4th and 5th metacarpal.
Closed fracture of the distal
4th and 5th neck. Metacarpal
of
neck.
the metacarpal neck.
Yep.
Which one?
4th and 5th.
5th.
Yeah,
Good.
5th.
So closed fracture of the distal portion of the 5th metacarpal And you can be cool and say with some angulation and maybe some minimal distraction, it's segmental in nature, only see 2 spots. Closed fracture, distal portion, fifth metacarpal. You know, and then sometimes, you know, if you just want to be cool, you can say boxer's fracture because the orthopedist isn't really going to care. Benet's fracture, Rolando's fracture. Rolando's is that proximal aspect of the first ray. I can see the Benet's fracture in there. Let's see. Refer to your handouts for Benet's fracture. Treatment, splinting above and below the fracture site, ORIF. That's a given in splinting. You guys are going to cover that more, I think, whenever you actually get to like your hands-on portion of your training later on in the year when you do splinting and IVs and all that other junk. But that's your general splint above and below the fracture site, above and below the joint of the fracture site. All right, phalangeal fractures, phalanges, right? Okay, more common than metacarpal fractures. Keys to stabilize the joint bone above and below the fracture site. Again, you use static finger guard splints, buddy taping, referral to hand surgeon if needed. Okay, nothing super fancy about that. There's tons of bones in your finger. They can be fractured. Put them back together if possible. Splint it above and below the joint that it's fractured at. Buddy tape it and refer to a hand surgeon if needed, or refer to an orthopedic surgeon if you want. A lot of times they don't really do a whole lot, just some static casting. They can do surgery if you really need it, depending on how bad the fracture is. All right, thumb ligamentous injury. Thumb ulnar collateral ligament injury, also called a gamekeeper's thumb or skier's thumb. Why do you think they call it that? Yeah, snapping necks, right? And then you skiing with a ski, and you get your loops around your ski pole. You lose your ski pole, and then it rips your thumb back. Forced abduction or hyperextension of the MCP joint. I got mine diving after a fly ball in a slow pitch softball game. And who gets hurt in slow pitch softball? This guy. Needed surgery for it. Basically, just anything that pulls your thumb back down under. MCP joint tenderness. Valgus stress testing shows UCL instability, so you can just, the way my hand surgeon says, like, yeah, well, it's you got a, gamekeeper's thumb there. We can numb it up and do some stress testing if you want, or we can just do surgery. So they can numb it up and just kind of pull on it and see, if you've got a ruptured tendon, your thumb's going to go all the way down. Shouldn't do that. Surgical pinning, screw or an anchor, thumb spica followed by physical therapy. Gamekeeper, skier's thumb, UCL. Right. Okay, extensor tendon injuries. So mallet finger, most common injury of the finger, damages the terminal slip, the extensor tendon, the DIP, going direct below to the finger. Inability to fully extend the DIP, fully extended. X-ray for fractures, make sure there's no associated fractures. Non-surgical full-time DIP splinting with extension and hyperextension, so they even bend it up. I think I have a picture of that. For 6 weeks, followed by part-time splinting. Surgical, for complete lacerations. Sudden, I said sudden force. Yeah, I got it. Rupture of extensor tendon right there. DIP, extensor tendon, can't extend it out, right? You can walk around with one of those cool things. I think I just walk around with a deformed finger. I don't know if I want to splint like that. Flexion deformity of the PIP joint, so Boutonniere deformity. Boutonniere. Flexion deformity of the PIP joint with hyperextension of the DIP. Lots of PIPs, DIPs, splint with full extension for 6 weeks. Boutonniere deformity. Right? Flexor, I need all these tendon injuries. Flexor tendon injuries, jersey finger. Rupture of the flexor digitorum profundus occurs with sudden forceful hyperextension of the DIP joint. Usually a lot of football players get it from tackling somebody trying to pull at their jersey and it rips their finger backwards. Inability to actively flex the DIP, so flex, extend. Splinting with aluminum finger guard, slight flexion, surgical repair if really bad damage ligament. flexor digitorum profundus, rupture. Stenosing Tenosynovitis, also called trigger finger, caused by disparity of the flexor tendons at the A1 pulley. God, when you do if you do a surgery rotation with like an upper extremity or a hand guy, you would have no idea how much anatomy is actually in the hand. It's ridiculous. It's way more than we've ever actually got taught. There's so many pulleys and all sorts of stuff in there. Anyways, flexor tendon catches and gets stuck. Painless catching of one or more of the fingers during flexion, sometimes caused with the finger to stay in flexion, and you need passive manipulation to get it back in. So that's why it's called trigger finger, because it gets stuck in flexion. So you can see this nodule getting trapped. A1, A2, A3 pulley. A1 pulley gets stuck. Like trying to get through that to extend it out. Pulley, A1, gets stuck. Trigger finger, Stenosing Tenosynovitis. It doesn't always, it like gets stuck, but then you're just like, and it comes back out. But that gets annoying all the time if you have to continually do that. You can try some steroid injections right into the sheath and see if that helps with the inflammation, or you can do some surgical therapy in failure to conservative treatment. All right, Quervain tenosynovitis, a tendinopathy that affects the adductor pollicis longus and extensor pollicis brevis. Not well understood, idiopathic versus overuse. I tend to go towards more overuse. Pain is located in the radial side of the wrist, exacerbated by movements of the wrist. Finkelstein's test. I will ask you about Finkelstein's. It's in your lecture notes. Look it up. Dupuytren contracture. So this is another one characterized as progressive fibrosis of the palmar fascia. Benign, slow disease. I bypassed Finkelstein's too fast, but I think we have enough for it. So you get these a lot in textures, texture of the thumb, right? Adductor pollicis longus, right here, right? That muscle goes right through here. And you get these textures. Finkelstein's test, just grab your thumb, extend your wrist down, and it shoots pain through that adductor pollicis longus. Finkelstein's test. Quervain's tenosynovitis. 15-year-old girls that send 5,000 text messages a year come in and they're like, oh, it hurts right here. Finkelstein's test. Quervain tenosynovitis, right? One of you guys is going to forget that. And if you rotate with me, I get really mad when you forget stuff that I taught you. So if you know that you have a rotation with me, review my lecture slides and at least remember the stuff that I taught you. Anyways, Dupuytren contractures characterize progressive fibrosis of the palmar fascia, mostly 50-year-old white dudes. Progressive loss extending to the 4th and 5th digits. You can do a palmar fasciotomy. This is a very difficult surgery. These people have contractures of their palmar fascia. Their hands basically look like that. And you can do a fasciotomy, but it's a tough surgery. A lot of complications, long recovery time. So it is, you can see how there's contractures of this palmar acroneuroses, the palmar fascia. You see this big cord right here. Okay, so now I think we're going to go into some soft tissue infections. Do you guys have any questions over kind of this hand stuff? This isn't all the hand stuff. Like I said, I think we could spend weeks on just the hand and all the different things that go with the hand. This is kind of, I think, some of your more common things that you see in primary care, urgent care, ER, and orthopedics, and just kind of some basic stuff that you're going to deal with. Anybody got any questions over any of that stuff? Nope. Okay. Hand infections. See a lot of hand infections. My God, I see a ton of hand infections. Human animal bites, pathogens, human, group A strep, E. cordens, staph, animal, Pasteurella, staph strep. Cats are the worst, got long teeth. They get that bacteria on their teeth, and their teeth go in further into the soft tissue and seed that bacteria, sometimes into the tendon, sometimes into the space below the muscle, below the tendon, in the fascia, and that's really hard to get rid of. It's really hard to wash out. Debridement and extensive washouts treatment for these. You gotta wash these things out, and you know, a lot of times, you know, my nurses will come in and they're trying to be really helpful, and I love them. You know, don't talk crap about your nurses because they will be mean to you. Unless you were a nurse before, then you can't. I was a nurse before I went to PA school, so I can talk crap on nurses, but you guys can't. And they'll come over and they'll just kind of wash it out with like 30 cc's of water, like a normal saline flush, and call that good. No, man, these suckers need a liter of normal saline. And wash it out. Mix it with iodine or chlorhexidine. And make sure they're not allergic to either one of those two. And high pressure, extensive washout. Now some of these, you know, the smaller ones, I mean, you got like a 1 millimeter incision. It's hard to use an entire liter on a millimeter. But if you got an extensive injury from an animal bite or any kind of infection that you're trying to do, you got to wash it out. This is going to be so much better than all the antibiotics in the world. You got to wash it out. Loose closure if the laceration is bad. I rarely close animal bites or human bites, if ever. Don't put glue on them, because that's the same thing as closing them. You don't want to trap the bacteria into the area where it shouldn't be. You want the bacteria to be able to get out. Your body has natural processes to push that stuff out. Making a close, you know, surgical or cosmetic closure or putting a bunch of glue and steri strips on is trapping the bacteria inside there, and I guarantee you, you will develop an abscess, you will develop tenosynovitis, and you will get sued. Don't do it. Now, you start to run into some difficulty. There's obviously minutia for everything. What do you do when you have a kid that has, you know, a big lac on his face, or very extensive open lacerations that, you know, if you don't close, they're going to get infected? That's where you do some loose closure. Now, caveat, I said the kid that got bit on the face, I don't do that. I send that to OU Children's, let a plastic surgeon do that. But all the other stuff, loose closure. Tack together a couple of stitches to hold that skin together so it doesn't look like, you know, they're Frankenstein walking around there, but loose enough that it'll still kind of bleed and pus out and let that stuff get out. You got to get the way to get that bacteria and stuff out. Antibiotics, augmentin works good for both human and animal bites. And there are obviously a bunch of different antibiotics that you can use depending on, you know, somebody has a penicillin allergy or whatever. Those are in your lecture handout notes, review them. And infections, paronychia is inflammation and infection along the, involving the proximal fingernail folds. Erythema, superficial abscess formation. Treatment, warm compress, oral antibiotics. I like Keflex for soft tissue infections that aren't MRSA. I think it works good. Topical does not work well. If there's an abscess, you've got to ID it. You know, a lot of the literature and all the stuff say that they don't really need antibiotics. That just IND, opening them up and doing warm compresses is good enough. But I'll still put them on antibiotics sometimes, depending on the severity of it. Paronychia, small abscess formation. Got to cut into and get those open. Now you can do just a small punch with like an 18 gauge needle, just stick it in there and get that stuff to drain out. Or you can do like a digital nerve block and do a straight line incision with an 11 blade scalpel and open it up and get all that stuff. Got to get that open and out there. And it's a pain relief tool too. Once they get all that pressure out of there, it stops hurting as much. You know, you can't just give these antibiotics and say, see you later, alligator. You got to do something about it. All right, infective tenosynovitis. Flexor tenosynovitis. Infection spread along the flexor tendon sheaths. Pulleys, those cool pulleys, facilitate the spread of the infection. Thus, you don't really see extensor tenosynovitis that much. It's more on the flexor aspect because of how the pull, I'm like doing this so I can see it, how the pulleys will help spread that infection. Infection causes necrosis and possible compartment syndrome. Bad. Mechanism, so traumatic implantation puncture wound. Somebody hit their hand on something, punctured something, and didn't really think about it, and they got that bacteria stuck down in there. Or you can have a hematogenous spread. Somebody who has bad gonorrhea or some kind of systemic mycobacterium can be seeded from a bacteremia. That'd be bad too. You know. Tenderness along the course of the flexor cheek. Slightly flexed finger. Pain with passive tendon extension. All capitals. Pain with passive tendon extension. You give these people, it's big and full, and you just move their finger back like this, and they're wanting to jump off the bed. I don't have this in here, and for some reason it's not off the top of my head, but there is a list of symptoms associated with infective tenosynovitis. It's like it has a dead guy's name or something like that. One of them is sausage digit. Look that up or look in your lecture notes. They should be in there. That's also another thing. I apologize, I can't think of it off the top of my head. But it's a collection of signs and symptoms for infective tenosynovitis. Your biggest one is going to be your slightly flexed finger, pain with passive tendon extension. And then, of course, it's going to be erythematous, it's going to be big sausages, it's going to be painful, they may or may not have a fever. Treatment, surgical debridement and IV antibiotics. Bank plus Cipro or Rocephin are good antibiotics to use for that. This is a, depending on how, much your hand surgeon really wants to come in and do this, this is a surgical, I'm not going to say emergency, but urgency. This is somebody that needs to be admitted to the hospital. They need IV antibiotics, and they need to have get their hand opened up and washed out by a surgeon. I have had 1 or 2 cases where the surgeon told me to send them home and follow up with him in the clinic in like 24 hours or 48 hours. I didn't like doing it. I did it. I think everything worked out pretty well, but that's going to be something up to your comfort level with what you decide to do, and make sure that you document your chart, that you talk to the surgeon, and that's what you recommended. Oh, I put it in there. Canaval signs. Sorry. There you go. Look. 4 canaval signs for flexor tenosynovitis. There'd be a test question. The guy's not flipping you off. He just can't. He just can't get his finger in. It's a slightly flexed finger. And so you can see how this erythema starts to track down that tendon sheet. You see how it kind of goes down here? Right? Yeah. All right, compartment syndrome. Increase, do you guys know about compartment syndrome?
Yes.
Okay, good. Well, there you go. We need to talk about it. Tibia, most common long bone fractures, non-traumatic, pain out of proportion injury, persistent deep ache, paresthesias, right? You guys have the 5 P's to compartment syndrome: paralysis, pulselessness, poikilothermia, you guys got all that. Tense compartment with wood-like feelings. I mean, if it's tense, it feels like a piece of wood. Pallor from the vascular insufficiency, muscle weakness leading to paralysis. I mean, if it's to the point where they necrosed out their nerves or necrosed out so much muscle tissue that they have paralysis, that's bad. That's not a good sign. Measurement of compartment pressures performed by a qualified surgeon. I've never seen this done because I've personally never done the emergency department. I've never seen an emergency physician do it. This is done by a general surgeon. It's just this kind of like little instrument that they stick down there and it measures that compartment pressure. Over 25 equals no tissue perfusion. Treatment is decompression fasciotomy. So where you go through whatever compartment, open up that fascia, and ends up looking like that. Or on the leg. Pretty nasty. But I mean, I would rather not lose my hand or arm and just have a scar like that. So. Questions? Over anything? That's it.
Thank you.
You're welcome.